So next is coronary blood flow. Okay, coronary blood flow can be asked in SAQ as a short answer question. Okay, so you have your ascending aorta, right? Then you have superior to your aortic valve. This is for MCI last time, we're very particular. Yes, it arises superior to your aortic valve, not inferior. It means it's above the aortic valve. This actually arises. Okay, the coronary artery arises superior to aortic valve, the exact location lah. So it comes to right side. We talk about right side here. Right side supply 1/7 of total coronary blood flow. Left side supply 6/7 of coronary blood flow. Means like this is like 20%. This is like 80%, roughly like that. Okay, and the right side. So you see, even another important thing is it comes out superior to aortic valve. At the aorta, there is pulmonary trunk also, right? So RCA comes in front of the pulmonary trunk. LCA becomes behind the pulmonary trunk. Last time it was asked in MTF. It comes like that. It comes in front or behind the pulmonary trunk. So it's okay. All this extra. So this is the part I wanted to say. So you see, RCA supplies 60% of SAN, 90% of AVN, because all your nodes are on the right side, right? All the nodes are on the right side. So the right side is the major supply for your nodes. Okay, 90%, and it supplies the RA, RE, left atrium, partly left atrium, and interventricular septums lah. Okay, all these things. Then your left coronary artery supplies your LV, LA, atrioventricular system. RA, SAN is 40%. Okay, so all these things. So by totally left coronary artery supply almost 70 to 80%, only 20% by your RCA. Okay, next. RCA, as I mentioned, it goes to your right atrioventricular groove. It becomes PDA and then anastomosis is part no. So LAD and circumflex, it runs in the anterior interventricular groove, run until the apex. Then it becomes anastomosed with your posterior descending artery. So this is your anastomosis here. Okay. So coronary blood flow, normal value is to 200 to 250 mils per minute. Percentage of cardiac output is only 5%. The heart is ejecting so much, but it's only taking 5% only for itself. So comparatively, renal 25%, brain 15%, liver 30%, GIT 20%. Why so low? It has a high extraction ratio. It means oxygen extraction rate. Even though only 5% coming into it, it's able to extract such an amount, 35 to 65%. Okay? So let's say you got 100 mils oxygen, it takes back 65 mils. Compared to your brain, liver, 20%, renal, 7%, everything. Okay, so it works vice versa. Why is it low? Because I have a high oxygen extraction ratio. Why the oxygen extraction ratio? Because only getting little, right? They have to extract as much as possible. So you can look at it in both ways. So relation of CBF to cardiac cycle. So this is another thing. When does the coronary flow occurs? During systole or diastole? We talk about the left side. Diastole, right? It's all related to your coronary perfusion pressure. The flow is always related to your perfusion pressure. So the coronary perfusion pressure related to, again, we talk about the left ventricle because the major pressure changes occurs in left ventricle. Right ventricle, the pressure changes are very minimal. It's not that significant. So the flow occurs during systole and diastole on the right side of the heart. Whereas on the left side, during systole, the pressure changes is such huge, so the almost flow ceases during systole. Okay, almost nil. That's why subendocardial ischemia, or most of the time left side ischemia, occurs during systole. Okay, the patient having contraction, severe pain, suddenly everything they will get. Okay, because during that time, almost nil flow. So because of lower pressure in the RV, the difference in flow not significant. Coronary perfusion pressure is the driving pressure for the coronary circulation. Coronary perfusion pressure is aortic pressure minus left ventricular pressure. The pressure in left aortic pressure minus left ventricle, if it's equalized at the same part, means there is no flow, zero, right? So it should be higher than only the flow because your coronary circulation comes from your aorta, right? So it arises from there. Aorta doesn't only supply the whole body, it supplies back the heart itself. So that's where the root pressure comes in. That's why we call it as an aortic root pressure. Larger the difference, more coronary flow. Larger the difference means the pressure gradient between the aorta and the left ventricle. Since most of the LV flow occurs during diastole, coronary, this one can be rewritten as your aortic diastolic pressure minus left ventricular diastolic pressure. So again, left versus right coronary flow. So this is the point that you have to write in your SAQ. Okay, left coronary flow occurs mainly during diastole, or in ARCH and VIVA, you have to mention these words. Reduce significantly during systole due to high left ventricular pressure, and mainly determined by heart rate. So this is why I say, okay, if the patient having ischemia, patient is a patient who are MI, come in anterolateral MI. The reason why they want them to be pain-free is one of the ways we want to reduce the heart rate. If you increase the heart rate, you're going to increase your myocardial oxygen demand more, right? The heart going to contract more, right? Every beat, there will be a flow ceasing, right? And you're cutting short of the diastole. Diastole is the part the heart is getting the oxygen. The patient is tachycardic, the diastole getting shorter and shorter, the period of ischemia going to recur. Okay, so diastolic time is 1 hour heart rate. So this is why I say, okay, that's what is important, controlling the heart rate in a patient who have ischemia. Okay, relation of CBF to cardiac cycle. This is to mention about the pressure lah. So remember about the left ventricle 120, 80 is your aorta. This is the one, aorta 120, 80 lah. Okay, I'll leave it to you all. This can be come out in the pressures of the chamber you must know. Okay, mainly aorta 120, 80, LV 120, 10. Why 10? The lower part, reaching the lower part. The 10 is the part that your vital valve opening and closing. The lowest. Doesn't reach 0, comes to the lowest. Aorta always at top, 120, 80. Okay, LV comes down all the way to 10. Your RA is 5, 25, 10, all these things lah. Okay. Okay, myocardial oxygen supply demand balance. So we know the heart is only taking 5% from its own cardiac output, right? So whenever it's already extracting 65 to 70% already, right? If you're going to give more demand to it, it can't increase its extraction ratio. So when there is a supply demand imbalance, that's when the ischemia occurs. So the demand is determined by all these things: heart rate, contractility, and your afterload. It means whatever making the heart difficult to pump. So this is the relation I mentioned. We talked about circumflex artery, lateral wall, right coronary artery, inferior wall, left anterior descending is septum and anterior, left anterior descending also these two lah. Okay, in your ECG, if you look at it, this is how they draw it. They put aorta here. So your 2-3 AVF is covered by your RCA. So if the patient comes with MI and you do an ECG, there is a 2-3 AVF elevation, you know RCA is involved. Then they go for Coros and PCI, they look for it lah. Okay, so if they have a lateral covers, as I mentioned, it comes here. How you place your ECG, right? You place your ECG, right? So that covers for your 1 AVL, lateral part of it. Okay, and V5 and V6, then your V1 to V4 will be all your left anterior descending. So venous drainage, just for MCQ, MTF purpose, 90% SAQ as well. If they ask you about coronary blood flow, don't only stop at the heart, arterial. You have to give at least one mark about venous drainage. It's coronary flow, right? We have to complete it. Okay. Remember, coronary sinus is the main part, mostly drain into coronary sinus, which is situated on the RA, accounts for 90% of it. Apart from it, you will have all the small vein, anterior cardiac vein, everything. What are the tributaries? All these things are small, middle cardiac vein, everything. Then you have to mention this part. Your Tibicean vein is draining directly into your left heart. So why importance of Tibicean vein? This is the shunt. This is the shunt. Because whatever draining directly into your left heart, if it's a venous drainage, it's bringing deoxygenated blood, which is going to mix with the oxygenated blood, which is coming from your pulmonary vein and entering your left side of the heart. So that's why this is important. Okay, Tibicean vein at the, okay. So sometimes they ask, last time there is very old question, write a short note about coronary sinus, 2 marks. So 2 marks, just have to write again, what is coronary sinus? It's a continuation of the great cardiac vein. It's actually a dilatation of the great cardiac vein. Okay, dilatation of cardiac opens into the right atrium at the near the IVC opening. You just write it's a dilatation of the great cardiac vein opening into RA directly. Okay, it's near the IVC opening, accounts for the 90% of the venous drainage of the heart. 4 points. Okay. So again, heart is drained by coronary sinus, two sets of veins. Here is a dilatation of great cardiac vein, opens into right atrium between IBC, near IBC is enough. This much is information enough, okay, about coronary sinus. So cardiac autonomic innervation, origin is from medulla, nucleus tractus solitarius. This is facts. Just take it as facts. We're not going to analyze it much, okay? Cardiac autonomic innervation. Autonomic means it has sympathetic and parasympathetic. Very good. So it has two components, okay? One that is increases the heart rate, increases the contractility. One is reduces. One is helping you to fight and flight. Another one is to rest and relax. Idea is increase oxygen supply. That's all. One is to increase the oxygen supply. One is to reduce the oxygen supply. Rest and relax mean reducing oxygen supply. Fight and flight mean they need more oxygen. It has to increase the blood flow, increase the heart rate, increase the contractility, but increase the supply of the oxygen. That is the idea of sympathetic system. Okay. Sympathetic. Okay. This is codo-ventrolateral, all this medulla, rostro-ventrolateral medulla. Okay. No need to remember. Okay, in your SAQ, if you don't write exactly all these things, nobody going to penalize you. As long you mention it comes from medulla and nucleus tractus solitarius. Okay, what you have to remember, it is a preganglionic and postganglionic fibers. All preganglionic fibers uses acetylcholine. Okay, doesn't matter sympathetic or parasympathetic, right? But postganglionic for sympathetic uses norepinephrine, whereas for parasympathetic it uses acetylcholine. That's the difference. Okay, acetylcholine is for rest and relax lah. Kan? Norepinephrine for your fight and flight. So preganglionic is the same. All are acetylcholine, but they are not muscarinic. They are nicotinic. We don't go into that depth much. Okay, just remember that it's not muscarinic, nicotinic. But in parasympathetic postganglionic, the one reduces the heart rate, that is not nicotinic, that is muscarinic. The one that prepare you for rest and relax in acetylcholine got nicotinic, muscarinic receptors, right? Nicotinic is all about contraction, skeletal muscle. Just keep it that it has central nervous system and muscular lah, NM and NN. Okay, we just think about the NM lah. Remember, nicotinic is for contraction, but the M is the one that for everything else. It causes all the parasympathetic symptoms lah. Your saliva, your secretions, your bradycardia, your bronchospasm, everything from there. Okay. So with the norepinephrine, the conduction is cardio-acceleratory. Increases everything. Increase contractility, increase heart rate. Okay, by the mean, increase the BP, increase cardiac output, increase oxygen supply. Okay, parasympathetic. So got the point? Write a short note on autonomic innervation. Autonomic innervation of the heart, origin from medulla and the nucleus tractus solitarius. It has sympathetic component and parasympathetic component. Okay, we write this, we add on points later. We haven't write about the nerve yet. Okay, we'll come into the nerve. So it is preganglionic ACH, postganglionic. You can just all write this in point form. Write all this in point form. Okay, and it's cardio-acceleratory. Whereas parasympathetic, nucleus ambiguous, this is like this part like exact, is it? That preganglionic ACH, postganglionic ACH is cardio-inhibitory. So one you write cardio-acceleratory, another one is cardio-inhibitory. Okay. So whenever we talk about parasympathetic, it's always vagus nerve, right? It's always vagus nerve. So the nerve that involved here is vagus nerve. You see here, for sympathetic, they doesn't use, they straight away the fibers coming directly. That is all about sympathetic. Sympathetic fibers are direct. Parasympathetic, they always use vagus nerve. So they're coming through vagus nerve, all these things. So this nucleus, what are the subtype of nucleus, the small nucleus after the NTS? It's okay. If you don't mention, it's okay. Okay, so this is the NTS. These are the rostro-ventrolateral nucleus and caudal ventral nuclear nucleus. You look at the sympathetic first. Sympathetic come in IML. This is ACH. ACH, your T1 to T5 is your sympathetic fibers for your cardiac. Then you get your norepinephrine. Norepinephrine works at beta 1 and alpha. Alpha 1 or alpha 2? For 1 lah. Okay. So it also others all lah, but it's 1, 1. Okay, so look at your parasympathetic, NTS, nucleus ambiguous, preganglionic ACH, postganglionic ACH, then it goes. So where do they go? They go to your cardiac conduction system, which is your SAN, AVN, Purkinje fibers, everywhere. Okay, exactly, no need to be worried about. Okay. So network of sympathetic, including sympathetic and network nerves, including sympathetic and parasympathetic system. No need to know in detail. If you want to write, let's say the SAQ, you want to write a bit more on the cardiac sympathetic system. Sympathetic, you write there, superficial and deep. If you want to write extra. If you don't read this part, it's okay. No need to know this exact thing. This you might need to mark up. I can't teach you the way to it. If it comes out in SBA, good luck for you all. Don't know how to remember. Okay. A bit too much to ask. Okay. Innervation, conduction system of the heart, coronary vasculature, myocardium. This is what I said. It affects everything. So conduction system of the heart means it's gonna reduces your heart rate, right? It's gonna reduces your, so the automaticity, right? The rhythmicity, all that get involved. Then coronary vasculature, they're gonna cause coronary circulation, vasoconstriction, coronary vasodilatation. Then they also measure myocardium. They're gonna directly interact with your contractility of the chambers. So they control the whole heart. So these are the pictures to see exactly the same thing. These are extra, for to see. Okay. So cardiac conduction system, electrical activity, we come into it. So this is where we want to talk about the components of the cardiac conduction system. Okay, piece of paper, right. What are the components of cardiac conduction system? Number one is your SAN. Okay, SAN. From SAN, the impulse go to AVN. So second. So second component is AVN. So next, bundle of East. Conduction system, number 3, bundle of East. Then it goes into your Purkinje fibers. Then you have your right bundle branch and left bundle branch. So 5 components. SAN, AVN, right? Then don't worry about this Beckman bundle, all these things. Okay, we talk about the simplified version. So what happens? Your atrial depolarization is initiated by the SA node, pacemaker. That's your pacemaker. It means that sets the pace. That's why I call pacemaker. It's making the pace for the heart. It's setting the pace for the heart. Okay. Then the ECG correlation, you all can just go through as I said. So first question, so you after you write the conduction system components, first sentence. Okay, first sentence you're gonna write your atrial depolarization initiated by SAN. Number 1 sentence. Second sentence, with atrial depolarization complete, impulse is reached at AV node and bracket slow down. You can write. It slows down at the AV node. SAN to AV node, the conduction is fast. The moment it reaches the AV node, there is a slow pause. Okay? As atrial depolarization initiated at SA node, impulse reaches the AVN after depolarization and slows down. Second sentence. Third, ventricular depolarization begins at apex. So that is why this repolarization, this part, QRS complex. Your ventricular repolarization starts from apex and go upwards, right? It goes downwards, upwards. Then ventricular depolarization complete. Ventricular repolarization begins at apex. So this is the whole thing, okay? So the pathway is this. SAN, signal generated by SAN. Pacemaker signal travel through RA, go to AVN. From bundle of East, it goes to bundle branches to Purkinje fibers into the walls of the ventricle. Purkinje fiber transmits the signals to contract the ventricle. So cardiac conduction system, this part okay, as a summary. Sinoatrial node, natural pacemaker in RA, AV node in interatrial system near AV valve, AV bundles, bundle of East, finally is your Purkinje fibers. Okay, this is next we go into, before we go into the action potential. We will draw a cardiac action potential soon. So we want to see how does it changes, right? So in action potential in the heart, you need to know about 2 things. You need to know about pacemaker potential and your myocyte action potential. Pacemaker potential means what happens in SAN. Okay, and what happens in myocyte means cardiac contractile muscle. Okay, so this is your SA node. We call it a pre-potential or pacemaker potential or SAN potential. The first part, ignore all the other things. Then finally you come to your ventricular muscle. You see the first one and then the final one. Okay, it changes in your morphology, changes in your duration, the length and everything. So first we talk about pacemaker potential. Look at this first. Don't look into what's happening. Just look at this. Okay, what is the resting membrane potential? Not in a cardiac muscle, not contractile muscle, peripheral nerve axon. Your pacemaker potential is something like your peripheral nerve axon. Okay, so which is, yeah, minus 70. In a ventricular myocyte or contractile, it is even lower, minus 90. Okay. First differences. Dah, dapat First refractory membrane potential pun dah lain dah. Okay. So next, you can see the phase 403. Missing, right? 1 and 2 is missing. Right? So whereas for the other thing must be 1, 2, 3, 4, 0 lah. Okay, there are different phases. We'll come into exactly how to differentiate. Okay. So what happens is your phase 4, phase 0, phase 3. You can see from resting membrane potential, it depolarizes, repolarizes. Simple as it. So this is in depth. So there's 3 phases. So you're going to draw this first. Each book says minus 70, minus 60. You keep it as minus 70 lah. So at phase 4, this is what we call as a pacemaker potential. It means it sets the pace. Let's say this becomes short, heart rate will be higher. That's why it's called the pacemaker potential. If that becomes shorter, it means you have tachycardia. Okay. Next, what happened as I mentioned here, T type, L type. How do I remember which one is which? Okay, L. I remember Lajula, L Lajula. I didn't remember L Laju, the other one was Biti lah. Doesn't remember transient or what lah. I remember L as Lajula because it goes fast, right? I remember. Up to you all, remember mnemonic, everything. Okay, no worries. Okay, so phase 0, rapid depolarization, opening of L-type calcium channel. Phase 03, closure of HCN and calcium channels and opening of K channels. So next we go to cardiac myocyte action potential. This is what you're going to write in exam. So phase 4 is your RMP, which is determined by your sodium potassium ATPase activity. Just write that. RMP minus 90 millivolt handled by sodium potassium ATPase activity. Enough. That point is enough. Next, phase 0, rapid depolarization occurs due to opening of sodium channels. Enough. Phase 1, partial repolarization. Sikit kan? Partial repolarization, closure of sodium channels and opening of K plus channel. Phase 2, flat 2, mainly by L-type calcium channel. There might be sodium channel there also. We keep it simple. Okay, we'll keep it simple. Then phase 3, repolarization, closure of L-type calcium channel and opening of K plus channel. Comes down. So when they ask you about refractory period, you're going to divide it into absolute and relative. One is no action potential can be generated. Action potential can be generated. 200 millisecond, 50 millisecond. 0.25, 0.25, 0.25. Already get 1, 2 marks or 1 marks. Let's keep it simple. Okay. If you want to mention this, important to ensure adequate diastolic filling of ventricle to prevent tetany. The period of this absolute refractory period, because we want to maintain the heart rate, right? The diastolic period. And your heart rate, your diastolic period determines your heart rate, right? So because we want to fill the heart. If you have another action potential here, before the left ventricular filling completes, you already got another left ventricular systole. Okay, because heart is pumping again. Okay, pacemaker versus myocyte. Okay, this is how we superimpose. You draw one first, then you just draw the pacemaker potential. So, okay, so these are differences. If your exam come compare and contrast, I'm not going to repeat it. You're going to just write this much. Occurs in pacemaker cell, occurs in ventricular cell, driven by funny current cell, driven by stimulus, unstable RMP. Because pacemaker potential doesn't need stimulus, it's automatic. That's why it's called automaticity. Okay, for this you need a stimulus. Unstable RMP negative 60, stable RMP minus 90, only 3 phases, 4 phases. Automaticity is possible, automaticity is not possible. Enough points. You want to mention about the refractory period, you can mention. Pacemaker potential doesn't have refractory period. Ventricular myocyte perfusion potential has refractory period. You can mention that extra important, extra point. Okay, again, if don't superimpose, that's how it looks like. Okay. Then in Kerry Brandis, they gave an extra lengthy information of these two. Okay, if you want to read about it.